So we're going to get started on the afternoon session in the hopes of trying to keep on time as best we can. It's my pleasure to introduce our first speaker, Dr. David Chascsa. David and I have something in common besides being hepatologists. We both went to high school here in Phoenix at Brophy, which, if you've been watching the news the last couple of weeks, I hesitate to tell you is an all-boys Jesuit prep school. But I'm confident neither of us will ever be nominated to the Supreme Court, so we're okay. David did his GI training at the NIH, and then fortunately for us, came and did a one-year transplant hepatology fellowship here at Mayo Clinic, Arizona. And we were fortunate to keep him on staff as of last year. David is going to be talking to us about cirrhosis and complications thereof and portal hypertension, and it's an opportunity for me to put a plug in for all of you to complete your evaluations, because we really do look at that, and this topic was specifically requested by some of the attendees of last year's course. So, David?
Thank you. All right, I hope you're all awake from your post-lunch coma. This is a big topic, so we'll try to stay on time as much as possible here, but we do have a lot to cover. So as Tom said, we'll be discussing the management of cirrhosis and portal hypertension. So really probably the most common question I get asked from patients is, what is cirrhosis? So just as a quick reminder, it's histologic changes in the liver leading to the development of fibrosis, which ultimately leads to architectural distortion and formation of regenerative nodules, giving the characteristic CT findings and macroscopic findings we see here in the pictures below. Ultimately, this results in a loss of functional hepatocellular mass and loss of liver function. So we grade the severity of cirrhosis in multiple different ways. There is a dichotomous grading system, which really we look at whether there are any complications related to cirrhosis. So if there are no clinically apparent complications, we call that compensated cirrhosis. And if we do note complicating events such as ascites or development of varices, which we'll talk about later. We call that decompensated. And that's important because life expectancy is vastly different based on whether you have compensated or decompensated cirrhosis. A compensated cirrhotic has a life expectancy of greater than 12 years, whereas someone that's decompensated has a life expectancy of less than 2. There are two major scoring systems for looking at mortality related to end-stage liver disease. Those include the Child-Turcotte-Pugh score and the MELD score, which is now adjusted for sodium. The MELD score is easily calculable online. No one would ever remember the equation,